hit record. Okay. So, and you can all see my screen, correct? Okay. So thank you for being here. Today this is our third presentation that's part of our three-part training series. And today we're going to talk about comparative clinical effectiveness research. At any point, feel free to ask questions. You can raise your hand. You can put your question in the chat. Okay, so first we want to do our land acknowledgements. We at UCR like to respectfully acknowledge and recognize their responsibility to the original and current caretakers of this land, water, and air, the Cahuilla, Tongva, Luiseño, and Serrano peoples, and all of their ancestors and descendants, past, present, and future. Today, this meeting place is home to many Indigenous peoples from all over the world, including UCR faculty, students, and staff. And we are grateful to have the opportunity to live and work on these homelands. We also want to acknowledge that this project is funded by PCOR, which stands for Patient-Centered Outcomes Research Institute. We also want to recognize that PCOR is an independent nonprofit organization. I know we've talked about PCOR a lot. This is authorized by Congress in 2010 to fund comparative effectiveness research. So we will talk a lot more about comparative effectiveness research today. Similar to last time, I would like to start with an interactive activity. So if you could either put in the voting code into Menti 22051812 or scan the QR code that's here. If you could list all the words that come to mind when you think of research interventions in healthcare. So we're thinking about what is intervention research in healthcare. I'll give you another minute to make sure you scan the QR code or put in the numbers, the voting code for Menti. And again, remember, the task is to list all the words that come to mind when you think of interventions in healthcare, and specifically in the context of intervention research. And Evelyn, if you could share your screen with the Menti word cloud.
Yes, I'm opening it.
Thanks.
Oh, sorry, there is something that is different. So wait a minute, I will share it.
So I'll go ahead and start reading. And feel free to add more as things come to your mind. So we have listed here ways of doing things: experiment, improvement, control, risk reduction, target gift card, strategic treatment plan, comprehensive. So I see definitely that we have ways of doing things, thinking about maybe that falls within the idea of research design, improvement, perhaps thinking about improvements in healthcare and patient outcomes. Comprehensive, perhaps that is related to research design, consultations, vaccines, surveys, strategic treatment plan, risk reduction. Okay, so let's take a moment to talk through these. So when we have target gift card, which makes me laugh a little bit, but it's very important because that suggests to us that we likely are giving a target gift card to someone. So this is an example of an incentive in clinical research. Clinical research involves humans. We're looking at health outcomes of humans. And so incentivizing them, providing them with some type of thank you gift at the end of their participation, or even at the beginning of their participation, is often something that we do. It's always something that we do. Not necessarily will we give them a gift card, but we will in some way reciprocate their participation in research. Would anyone like to comment on any of the other words that have come up? A lot of the other words remind me of design or thinking about the research questions, how we get the data, how we collect it. So one thing that I don't see is comparisons. So one of the things that we'll talk a lot about today is how can you compare evidence? I also don't see on this evidence either. That's another topic that we'll talk about. Why is evidence important? Why does it matter when we think about interventions in the context of healthcare? Okay, thanks, Evelyn. Okay, so today, the goals of our talk. First is to discuss current campus, on-campus and off-campus treatment of students with mental health concerns, understand the meaning of evidence-based interventions, introduce concepts of efficacy and effectiveness in research focused on interventions in healthcare settings, and then last, to discuss how students, the campus, and community partners can use this approach in research. To acknowledge our partnership, this is a partnership in collaboration with Solid Ground Wellness and Recovery, as well as University of California Graduate and Professional Council, and UCR School of Medicine. Okay, so there are many off-campus services for students, and we'll talk about one off-campus service, but on campus, when we think about mental health care services for our students, there's CAPS, which is counseling and psychological services. CAPS provides in-person and virtual, meaning telemental health services to registered students. So CAPS, you can see here, it is open it's not open 24/7. It's typically open during business hours. However, there is a hotline and students can any registered student can access this service. It's also free. So if a student is registered at UCR, then they can access mental health care services at CAPS, Counseling and Psychological Services. Solid Ground Wellness and Recovery is a drug and alcohol rehab treatment center in Riverside. And our partner, who is here today with us in our meeting, Lisa Molina, is one of the founders of Solid Ground Wellness and Recovery. So Lisa, would you like to add anything about Solid Ground Wellness and Recovery?
I think that we just really try to meet the individuals where they are. We provide services both to youth as well as adults. So there's a spectrum of age ranges of the people that receive the services as well as provide the services. And we really do focus on emotional wellness. So although primary services are substance abuse treatment, we do take the whole person into consideration. And so we're working on basically emotional wellness in all areas of their life. So removing the substance doesn't necessarily remove the barriers that they may be experiencing. So that's just addressing that, and then either providing resources or tapping into resources outside of us that would get the needs met of the individual.
Thank you. So let's take a moment to talk about CAPS. So some of you may know CAPS. You may have used their services, or you may have walked by their services. They're located right next to student healthcare services. It's actually in the same building. It's a different wing of the building. So the services that are offered on campus services for registered students, as I mentioned before, they offer referrals to on-campus services. So this could be case management, for example, or perhaps collegiate recovery, or other services that might be part of wellness. And in addition, they offer referrals to community services and resources. So for instance, CAPS therapists might make a referral for a student to Solid Ground Wellness and Recovery. So there are many different organizations within the community, services that our clinicians or our therapists within CAPS, they can make referrals to. Lisa, do you want to mention anything about referrals?
Those are actually generated by the client. So the student would actually, when they meet with CAPS or us, then they would contact the CAPS, and they're the ones that do the referral. So it is generated by the student. And it's actually gone very well. There's been no hiccups for the individuals that have been referred. It's a pretty seamless process, and even with the insurance payments. So it actually works pretty well together.
Lisa, how do you know how students, for instance, at UCR, how they learn about your organization?
You know, honestly, I think that one of the things that I did early on was did the new sets of students that came, or the new sets of CAPS staff, we did a presentation for them so they're aware of the Solid Ground services. And then ours also, if somebody has a question, even if they're not, the intention isn't to use our service, but if they want resources for other community resources, we're able to help link those as well. But it's actually, I think, just the individuals that have been through the treatment with Solid Ground, and then, like I said, the staff that are part of CAPS, they are aware of our services. And I believe that they have brochures that I sent in as well.
Okay, thank you, Lisa. I also want to point out that UCR CAPS, for instance, that they have licensed psychologists, licensed marriage family therapists, and licensed clinical social workers. So those are the individuals that students would meet with if they access services at CAPS. And the intervention model is one of short-term counseling and psychotherapy. And so in conversations with leadership in CAPS, they've shared with me that it's a model of 8 sessions. And so it's not really intended for long-term therapy. It's a short-term counseling and psychotherapy. And so you can see where if a patient needs longer-term care, then it's great to have connections like Solid Ground Wellness and Recovery, UCR Health, for instance, where the student patient can have access to other services. And CAPS also offers individual and group therapy. So they have 2 different ways in which they can treat patients, whether in one-on-one or in a group setting. In Solid Ground Wellness and Recovery, they offer different services, so partial hospitalization, intensive outpatient program, and outpatient program that would be less intensive. Lisa, do you want to mention anything about the services you all provide?
Well, it's pretty comprehensive. We rarely will have somebody that's actually in the hospitalization or partial program. Typically, it's going to be outpatient or the intensive outpatient. And we do what they call an ASAM, which is a screening tool to identify areas that individual is struggling or that needs additional resources. And so based on that assessment, they would be it would be determined what level of care that they would participate in. And then we also take in other factors. So they may score needing intensive outpatient, but because of work or school commitments or family commitments, they may not be able to commit to that. So we'll start them at a lower level number of hours, and if they need additional support, then we can increase it. But we will try to meet the student where they're at, or any individual that comes to us, where they're at, and we take into consideration the other commitments that they have in their life to make sure that this isn't going to add more stress, but hopefully to alleviate stress.
So it sounds like, Lisa, that you're very patient-centered, focused on What does the patient need at this point in their life? What are their current constraints? What would work for them?
And we also do offer groups both in the evening as well as in the morning. So we have a Monday group at 10 o'clock, and then we have gender specific groups on Tuesdays and Wednesdays, men and women, or male and female groups, the gender specific for those groups.
Okay, thank you. So I want to pause for just a moment and say, the idea of sharing what different on and off campus systems, healthcare systems, or I don't want to necessarily say healthcare systems, but mental health services, what kinds of services and resources they provide to patient populations. Because we want to think through today, how can we actually consider the implementation of interventions within these systems of care? And so recognizing, for instance, that students can access services within the context of the campus environment, that's really important because it could potentially break down barriers, right? If you're walking by counseling and psychological services on campus, maybe you'd be more familiar with it. You'd start learning about it possibly. However, if you're concerned about accessing services in your campus environment, and you have a car and you're really interested in going off campus, then this is an opportunity for you to get services off campus, right? So when we think in research, we want to consider, what are the different ways that people can access healthcare services? How do we want to start thinking about that when we think about improving the health conditions of patients who are in our clinical research? And that's, along the lines of healthcare access, intervening in that way. So I want to point out that both UC Riverside CAPS and Solid Ground Wellness and Recovery, that they use evidence-based practices. So they use cognitive behavioral therapy. CBT challenges faulty thinking patterns, emotional responses or behavior, and replaces it with a more appropriate or desired thinking pattern, an emotional response or behavior. If we take a look at the right, we can see how behaviors influence feelings, feelings influence thoughts, thoughts influence behaviors, or the other way around, behaviors influence thoughts, thoughts influence feelings, feelings influence behavior. What's important is understanding that behavior, thoughts, and feelings are connected. So if we change one, then potentially it can change others, behaviors, thoughts, or feelings. Motivational interviewing is a technique which translates respect and acceptance of the participant and their feelings. It's non-judgmental and collaborative. It's person-centered, goal-oriented, and the decision is to change comes from the client. Here is an example or an illustration of motivational interviewing, thinking about goals, thinking about change, thinking about what the problem is, thinking about the cons of a goal. So very much identifying where the patient is, where are they, for instance, if we consider the idea of mental health among student populations. So is the student, does the student recognize that perhaps they have anxiety? Or is the student unsure if they have anxiety and what possibly could be done if they do have anxiety? So meeting the patient where they are and starting there and understanding what needs to be done and what is the patient, the student patient themselves, where are they ready to start? And then how can you move forward from there? So why does evidence matter? Let me pose it as a question to you all. Why does evidence matter? So we're talking a lot today about evidence, evidence-based practices. Why does it matter? Evelyn?
Yes, I think that the evidence is important because we need to identify the resources that we are using, like for instance, the theory or the approaches that are informing our practice. So the evidence could be prior research, right? It's just like, okay, what others have been doing, Also, for instance, whenever we are thinking on working with historically marginalized communities, it's also important to notice what are the approaches that better address their needs. So I think like this also evidence help us to change some approaches or even paradigms, I don't know, sorry, in our practice, right? So like it helps us to move away from these taken for granted approaches that sometimes inform mental health or also health services.
Mm-hmm. Okay, thank you. Anyone else? So I want to point out, it was shared in the chat that sound decisions for treatment ethics. Absolutely. So these two, Dr. Vasquez mentioned research evidence. So if we take a look at this image that's in front of us, this model, Dr. Vasquez referred to research evidence and evidence-based theories. So this represents, we could say, academics. And in the chat, it was mentioned sound decisions for treatment ethics. That too could come from research. It could come from clinical experience, expertise. It could also come from patients. Their patients voicing their own preferences or voicing how ethics might shape their decision-making, for instance, around health. So I really like this model because it illustrates the different perspectives and voices that are important when we consider the creation of evidence. Here we can see that it's important to consider how have patients informed evidence. So how have their preferences and their values been part of the creation of evidence? How has clinical expertise and evidence from assessment of the patient's history and conditions, as well as healthcare resources, how has that been factored in to the creation of evidence? And then how is research, which when we think of research, we're thinking specifically of a systematic investigation in which the goal is to contribute to generalizable knowledge. So how does research help us in this context? Together, research, clinical expertise, and patient perspectives contributes to the creation of evidence and informs clinical decision-making, and ultimately that influences patient outcomes. So we can't have one or the other. We need all three in this case. So I want to ask the question, would it be possible to see, for example, if cognitive behavioral therapy works differently depending on whether it was delivered via telemedicine or in person? Could we design a study around a question like that?
I would say yes.
Okay, Lisa?
It actually does work. We're able to utilize the same tools under telehealth as we are in person. But I think really the biggest barrier or factor is the willingness of the participant. So that it's going to make a much more big difference if they're focused or what they have going on around them. So there may be some barriers to being able to have a CBT effectiveness if there's a lot of things going on in the background on telehealth versus if they're in person. But it really does depend on the individual.
Okay, thank you. Evelyn?
Yes, I also would like just to add that another key aspect to whether this would be possible, it is the conditions of our patients, right? Whether they have access to internet or also if they have digital skills, for instance, or digital literacy, because even if we have all this infrastructure, if they don't have access to internet or they don't know how to use these technological devices, probably this approach would not be helpful.
So I'm just noting so that when we get to the very last slide, we can come back to this. So I want to recap. Dr. Vasquez mentioned conditions of patients. So thinking about what's their access, their digital access. That's one thing. And then Lisa, you mentioned we're unsure about the outcomes of CBT, its effectiveness, whether it's in person or if it's virtual. So we know both work, but it sounds like from what you're saying, we don't fully know. And maybe, in the context of your clinical setting, we don't fully know which one's better, which one's working better. Did I capture that correctly?
Yes, and I think also it depends on what they have in the, like I said, the resources that they have. So if they have somebody that they have small children, that somebody that can watch the children while they're doing this, as opposed to trying to do a session and control maybe a child that needs, some attention at that point. So I think that it can create additional barriers through that. I know that's a little bit off of the subject matter, this whether CBT is effective or not, but I think it really matters the resources that the individual has, which actually kind of dovetails nicely with Evelyn's statement.
Definitely. Any other thoughts or comments? Again, this is a learning space. There's no right or wrong answers. We're here to work things out and think through things. Okay, so we will revisit this. Moving on to comparative clinical effectiveness research, or CER is what we often refer to it as. So first I want to step back and talk about what is clinical research. So NIH defines clinical research as studies conducted in collaboration with human beings, undertaken to improve health. So when we think about clinical research, we are specifically thinking about research that is intended to improve human health. That could be individual health, community health, population health. But the idea is improving human health. There are many different types of clinical research. FDA indicates that some of the types of clinical research that they define include treatment research. So this focuses on interventions, prevention research, focus on preventing illnesses, disease spread, lifestyle change, epidemiological studies. This looks at diseases often at a population level. And then there's clinical trials. Clinical trials are intended to test interventions or treatments. When we think about common designs within clinical research, we might think of a pre- and post-test design. This is, while important, often considered a weaker design. Another example, is comparison groups. So when we're thinking about how we're going to design a study, if we have 2 or more groups to compare, then this is considered stronger, much stronger than a pre- and post-test design. In a pre- and post-test design, you would be comparing individuals' responses at the beginning and the end of an intervention, for example. You wouldn't necessarily be comparing it to another group unless you had a comparison group. So that's where we can see that an intervention, we can begin to understand it if an intervention is good, if it really is having an effect on health outcomes, if we can compare between groups. And then there's the gold standard, which is a randomized controlled trial. Okay, questions on clinical research or any of the types of clinical research that I've shared or the different kinds of designs? I will add, randomized controlled trial is considered the gold standard because you are randomizing. You are placing at random participants in your study into one or more groups. So you might have a randomized controlled trial that has your treatment group and your control group. And so what this means is that in your study design, your participants, they don't choose to be in one group or the other, they are randomized into one of those two groups. This is considered the gold standard because when we can place individuals, participants in a project, in a study, into one of two groups at random, it allows us to better understand if it's the intervention that is really making a difference in terms of our outcome variables. So that's why we consider randomized controlled trials to be incredibly important within the context of clinical research. And I want to pause for a second and ask Dr. Lakes if there's anything that you would like to add. Dr. Lakes has a lot of expertise in randomized controlled trials.
I think it's there's certainly, you're right, it's considered the gold standard. There are times when it may not be the best approach. And I hope that's maybe where you're going to be going with some of the next slides as well. But it is, considered very rigorous because you are randomizing participants to treatments. And so they don't have a choice of which treatment they're going to receive going into the study. And then, you're also to use masked evaluators and to get outcomes that are as unbiased as possible, that go beyond self-report and, observer reports, so that you can really detect a meaningful difference. And I think that, they're typically the easiest types of studies to get published because they're recognized as a gold standard approach. But in community settings, as I'm sure you're about to tell us, they're not always practical. In my experience doing school-based research, it's not always practical or feasible. So it's not the only way, and it's, I think, not the only meaningful way, but certainly is the way that medicine has typically tended to investigate intervention.
Thank you very much, Dr. Lakes. Yes, absolutely. We are going to talk about another way to think about evidence-based practices and interventions and evaluating them. One of the things I do want to add, so Dr. Lakes mentioned, or one of her comments made me think about ethics and randomized controlled trials. This is something that as an investigator, I often struggle with.
We're gonna go meet in the cafeteria right now.
If,
and then actually meet.
Okay. If we consider doing a randomized controlled trial, for instance, in a vulnerable patient population that has limited access to interventions, then how do we as investigators need to think about what if you are part of that underserved patient population with limited access to an intervention and you are placed in the control group? The control group doesn't get the treatment. And so it raises concerns about ethics in research. And is it in a context where for science, we want to understand, does this intervention work? But how could it potentially harm in various different ways the actual patient population who in the end could benefit, but in the immediate time, it might be harmful to them in that context. It could be disruptive. People could get upset. They could get angry. It could create disruption, right? So those are things that we need to consider as investigators in terms of the ethics around this kind of work. So what is efficacy? Now we're going to talk a little bit about efficacy and effectiveness, and then effectiveness trials. So efficacy is how a treatment or an intervention works in a controlled research environment. When we think of randomized controlled trials, we are thinking about a controlled research environment. How is a treatment or intervention, how do they work for specific populations? So when we design a study like this, we have very strict inclusion-exclusion criteria. What are our statistical analyses? So thinking about the analyses only on those who complete the treatment. And is there an inherent potency of the treatment? So really thinking about when we consider this type of work focused on efficacy in very controlled environments. So I just want you to keep that in mind, the idea of using specific and very strict inclusion-exclusion criteria, and then thinking about, Dr. Vasquez mentioned the other day, when you're doing a controlled trial, for instance, to think about efficacy, you're doing it in a box. And what is effectiveness? So thinking about how a treatment is known to be efficacious works in the real world, something that Dr. Lakes just mentioned. So how does a treatment work when applied to populations across the board, where you have minimal exclusion criteria? And when you think about statistical analysis on all the purpose, so with the idea of intent to treat, and what's the practical application of the treatment within clinical settings? So again, what I want to emphasize here is the idea of real world with minimal exclusion criteria. So how can we understand and do a study around thinking about the effectiveness of an intervention as it's implemented in a real world setting with patients? And what's the practical application of the treatment? So an example of efficacy versus effectiveness. Antidepressant medications are shown to be efficacious 85% of the time. Antidepressant medications are shown to be effective 60% of the time. Why is this the case?
Would it have anything to do with compliance?
It certainly could.
So there's a lot of uncontrolled factors. For example, then our RCT, randomized clinical trial, they probably screened out the people who are going to be the most complicated to treat. And in a community setting, you're not going to screen them out. You're going to provide them treatment anyway, but they might be more complicated and more difficult to help.
Mm-hmm. It's often common, I've seen in studies, to exclude, perhaps based on co-occurring conditions, so that there can really be isolation of a focus on a particular mental health condition, for example. Mm-hmm. Any other thoughts? Just thinking back to the words that I shared before. So in this case, efficacy, we're thinking in a box, right? An investigation in a very controlled environment with restrictive or very strict, sorry, not restrictive, very strict inclusion and exclusion criteria. And then when we're thinking about effectiveness, we're thinking about real world settings as people live out their daily lives, as people exist in the world, right? So one is very controlled, one is real world. And so you can see when it's more controlled environment, what this is indicating right here. In a controlled environment, we can see that antidepressant medications, they're shown to be 85% effective. Right, 85% effective. Or, I'm sorry, efficacious. However, when we think about antidepressants in real world settings, they're about 60% effective. And here is an image to illustrate controlled setting. Very strict. We have very homogeneous sample, right? When we're thinking about effectiveness, it's real world, the diversity, multiple different backgrounds, characteristics, and factors that go into play in terms of the intervention impacts on outcomes. So continuing with the idea of effectiveness. So thinking about producing a definite, decisive, or desired effect in a real world setting. To show effectiveness, you have to have a specified, clearly defined intervention or treatment known to have efficacy. So the idea is that there's been a study that has proven its efficacy, for instance. So a study design that, like a randomized controlled trial in which the treatment or the intervention was determined to be efficacious. Intervention must have been used in multiple rigorous research studies which have established an evidence base. And so there's more than one study. The idea is that there's multiple studies that have proven the treatment or the intervention to be efficacious. Implementation, fidelity to the model. What this means is the idea of those who are implementing the intervention or the treatment are following a model, right? They're following a process, and that there's fidelity to the model, meaning that the individuals implementing the intervention or treatment are aligning with the expectations of how it should be implemented or delivered, and that there's careful measurement of appropriate outcomes. So when we think about the kind of research that we're doing, considering what are the outcomes that patients and other stakeholders consider to be important. And then there's a larger number of participants because there's a lot of noise, right? This is not in a controlled box. This is the idea of more in real world settings. And then there's often more sophisticated multivariate statistical analyses. So there's a lot that goes into research in general, but there's a lot we really need to think about when we're doing effectiveness research. So to recap, what is effectiveness research? An efficacious treatment, so this could be medications, psychotherapy, diabetes management program, that's tested in a real world setting using randomized controlled trials with a specific outcome measure or measures. After multiple trials, evidence begins to accumulate for or against effectiveness. And when there's preponderance of evidence that shows that the treatment or the intervention that demonstrates its effectiveness, the treatment then becomes an evidence-based practice. So, what is comparative effectiveness research? This is research that compares two or more treatments or interventions that are known to be effective. So that is that they're evidence-based. Comparisons often include many different kinds of measures: clinical outcomes, acceptability, feasibility, and cost. So I have two plants here as an example, kind of run through comparative effectiveness research at a very cursory level of plants. So Evelyn or Dr. Vasquez, if you could remind me, this plant on my left, it is a Monstera plant.
Monstera.
Monstera. And I'm not sure if we know what the other type of plant is.
No, I don't. I don't have any of those ones. But I don't know. It looks like laurel.
Laurel.
Could it be? Yes. Or I don't know if someone else is an expert. Oh, sorry.
Does someone else know what the plant on my right is?
Maybe an olive tree.
It kind of does look like an olive tree. Okay, so we're going to say we have our Monstera and then our olive tree. Did I pronounce that right? I don't know why, but I cannot ever, I have one of these plants in my house, but I can never remember the name of them.
It's like monstro. Monstera. Yes.
Monstera. Okay, so if we consider both of these plants as two different interventions, in previous studies, they have proven to be efficacious. They've been proven to be efficacious for improving mental health among individuals specifically diagnosed with depression. So essentially, it reduces, both of these plants have been proven to reduce depression symptomology. So in our clinical effectiveness research study, we decide that we're going to compare these two different plants. We're going to compare the Monstera to the olive tree. We're going to invite participants who have a history of diagnosis. So they have been diagnosed by a healthcare provider with depression. And we are going to randomize them to one or two of these groups. I should also mention they are current graduate students. So the inclusion criteria, they need to have a previous diagnosis of depression, and they need to be a graduate student in the UC system. So they take baseline. We do baseline assessments to understand what's their depression symptom look like, what are some general background characteristics, do they have any other kind of symptomology like anxiety? We also assess for that, but we're focused on depression. And we then randomize them. So they either get the Monstera or the olive tree. And then we follow them for 3 months. And at the end of the 3 months, we ask the same questions that we asked at the beginning about their depression symptoms. We also ask the same questions about their anxiety symptoms. But again, we're really focused on depression. What we notice when we do our analysis is that both of these plants work equally well. So they reduce depression symptoms among the student population, or I'm sorry, not population, that's the sample of students in our study. We also notice that there's some effects on anxiety in terms of reducing their symptoms of anxiety, but we don't notice anything significant. And we know that these interventions really were designed for reducing depression. So we say, okay, well, in the future, which one would we recommend? So then we might think about cost. Is it easier? No. Well, feasibility and cost. Was it easier to share with our participants the Monstera plant versus the olive tree in terms of how we get them to the patients? Is it more cost effective? So for instance, the Monstera costs $5. And we learned in our qualitative interviews around satisfaction with the intervention that students mentioned a lot about how they were excited to clip off pieces of the Monstera tree and share it with friends. And they were very excited about that. The olive tree is $25 per tree. Students really liked, in the qualitative interviews, they really liked the olive tree, but they weren't enthusiastic about sharing any part of the olive tree with their friends or family. So in this case, when both interventions work equally well in terms of the desired health outcomes, in this case, our desired health outcomes are to improve the mental health and well-being, specifically reduce depression symptomology among patients, which one might we choose? We have a limited budget. And what recommendations would we make, for instance, to practitioners, I should say practitioners who maybe have a limited budget, limited resources for implementing this intervention? Any thoughts, ideas?
Well, it would be the one that what they want to share that's lower cost because they're both effective.
Mm-hmm.
Unless,
Right.
unless somebody over here with the olive tree has, I don't know. I mean, an undue or unfair influence, right?
Mm-hmm.
Because I
Mm-hmm.
think there's that too. There's going to be like, who do you go through? And then what? I mean, without saying it, I mean, like that is one of the things. Like somebody might want to support the more expensive tree, but there may be other reasons for that.
Like there might be less of a bureaucracy to go through.
Maybe,
Mm-hmm.
or that, I mean, in a bad situation would be that they have a vested interest in selling the olive tree as opposed to the Montserrat tree.
Mm-hmm. Okay. Evelyn?
Yes, I think that also a key factor, for instance, is the factor of motivation to share with others. So what we know as well is to engage the importance of engage other marginalized communities, right? So if we are, for instance, hearing that most of these students that are part of the population that is the most meaningful or the most important for our work is choosing the Monstera, then it's important for us to put a little bit of attention of why. And if they say, well, it's because I can share with other peers or with other friends that are coming from the same backgrounds, then I think that is also an important aspect for all of the researchers, because then we can see what could be the long-term impact of that intervention. So yeah, of course, like the olive tree could be beautiful, but also it takes a lot of time to grow. probably 10 or 15 years or even more. And the Monstera, within a couple of months, you will see how the leaves are growing and something like that. So probably it's also because of the short-term effect or the long-term effect that might be also playing some roles in why the students were more interested in the first option than the second.
So great. Thank you both for sharing. Anyone else like to share? So one of the ideas that or comments that Dr. Vasquez just made reminds me, okay, so as this is our study, we might want to consider, let's say this was a pilot, when we do our larger study, that we want to follow the patients in both groups for a longer duration of time, because our qualitative interview has suggested, or qualitative data has suggested that there might be something really beneficial around the Monstera treat that we didn't initially anticipate, right? And we really want to think about what's best for patients when we're thinking about, and at least in context of patient-centered research and patient-centered clinical care, thinking about how are these interventions going to speak to the needs of the patient population, what resonates best with them. And Lisa, I feel that some of your comments were getting that as well. So if both are seen to be effective, then how do we help the patients choose which one might be best fit for them? Okay. So moving on. How does PCOR define comparative effectiveness? So comparative clinical effectiveness research. So comparative clinical, okay. I just had a moment in which I couldn't remember what CER stood for. So comparative clinical effectiveness research compares the effectiveness of two or more interventions or approaches to healthcare, examining their risks and benefits. What we know is that findings from CER studies can help patients and other healthcare stakeholders make informed decisions to improve healthcare. At least I feel very much what you were referring to is, if we know this as providers, if we know this as academics, if we know this as other healthcare stakeholders, how can we use this information to help patients make informed decisions? So for instance, as we just walked through, if a comparative effectiveness clinical research study on depression compares two different mental health interventions and the outcomes are nearly equal, such as they both improve depression symptoms, then patients can choose either intervention, right? And it would be the role of healthcare stakeholders to help patients, to present this information to patients, to let them know that two interventions can nearly equally improve their health outcomes. Then it's our responsibility to share that information with them so that patients can make informed decisions. And in the case of pediatric patients, sharing it with their caregivers so that they too are involved in making decisions about their children who are patients. But if only one improves depression symptoms, then we would want to encourage patients to choose the one that improves health outcomes, right? So this is how evidence can be used in the context of evidence created by comparative clinical effectiveness research studies. Okay, so I'd like to take a moment, maybe a little bit more than a moment, and talk about if we could come up with a comparative clinical effectiveness research study, what would it be? So let's take a few minutes to discuss possible future CER studies that would address mental health among historically marginalized graduate students, specifically in the UC system. So if we could take a moment to talk about what's the research question, what would be the design, what interventions could we compare, and what outcomes would we want to measure? So I'll stop sharing my screen and I will put those items in the chat so we could begin to think a little bit about that. And I encourage people to share any of their ideas via the chat or out loud. And I will ask if there's any grad student here if there's a research question that they've had, or if it doesn't necessarily have to, you don't have to think about it necessarily as a research question, but have you ever been curious about graduate students' mental health and thought, what if we could do this to improve graduate student mental health? Okay, so I am prepared to bring up our question again and to walk through this as our example. So earlier we talked about the idea, would it be possible to see if CBT works differently depending on whether it was delivered via telemedicine or in person? So if we consider students as our sample, for instance, what would we want to try to understand? So, or what do we want to work through? So if we think about our study design, what would our study design look like? Especially if we're thinking about comparative clinical effectiveness research, what would we need to think about?
I think that one of we can start by knowing what is the access that they have. Right? So, like, first of all, like, do they have access to mental health services on campus or off campus? Right? And then also would be another aspect probably will be what are the barriers to access mental health services. That it is also, and I'm sorry, but I'm just also linking some of our previous projects that many grad students, for instance, were talking about issues of time. And it's like, well, I don't have time, for instance, sometimes to go to CAPS, or I don't want to go to CAPS because then I can see some of my undergrad students there, right? So it's like, okay, what can we do to make sure that we can compare these two approaches that might be feasible, but then also accessible for our student patients that in this case are grads.
Okay. Lisa?
So I was also thinking that you would want to have like a level of, like, if you're trying to address depression, to what degree is there depression? Because it's going to matter, like, in the comparative, right? Well, I mean, you're comparing the two, but if somebody's getting CBT services as opposed to or it's in person versus telemedicine, you'd have to have a baseline of where they are with their depression currently to determine whether or not it was effective, right? So you'd have to have some type of questioning about where they're at, like how it affects the different areas of their life. So you'd have a from and to, something to compare to.
Okay, so we'd want to ask questions about their depression symptoms.
And then, as Dr. Vasquez said, as far as access too, so which ones have access or which ones have the availability.
Okay. So anything else that folks want to bring up? Okay, so just working with some of the ideas that are shared. When we think about what we're going to compare, so we're going to really look at these two different types of interventions, how they're delivered. So we want to know, in this case, does cognitive behavioral therapy, so we know it's an evidence-based practice, right? Does it work differently depending on whether it's delivered by telemedicine or if it's delivered in person? Some of the things we want to understand is across, like, whether individuals are randomized to the CBT intervention. Let's say the CBT intervention is seeking safety. So is it correct, those who are on the call who are clinicians, that seeking safety, I know it's specifically focused on PTSD and trauma, but it uses principles of cognitive behavioral therapy. Anyone confirm that for me? Off the top of my head, I'm pretty sure that's correct. So let's just say that our intervention is seeking safety. And we want to understand, does that intervention, does it matter how it's delivered? In terms of, does it matter, does it still, and this time where, because seeking safety is focused on PTSD and trauma, we want to ask questions that understand at baseline, what's the level of PTSD that patients have in our, or I'm sorry, participants have in our project at baseline, and then trauma as well, or I'm sorry, PTSD measures, basically traumatic PTSD measures people's responses to traumatic events, right? It could be a traumatic event that happened a long time ago, more recent, but it measures basically how have people responded to having been exposed to traumatic experiences and events. So we would want to definitely use a screening tool that allows us to understand where people are at baseline and where they are at the end of the intervention, right? And so what we're really interested is trying to understand, like, in a student population, does it matter if students get this treatment via telehealth? So they could potentially be in their room on campus, in their dorm. They could be at home with their family. There's many different ways that they could access. They could even access telehealth theoretically in an airport, or they could be at Starbucks. There's, many different ways that they could access telepsychiatry or telemedicine, right? Or are outcomes better when it's in person? So when we design our study, we might want to say, okay, if you are randomized to the telemedicine, we do expect that you are not in a public setting, right? So we could put some parameters so that we could better understand how the intervention might work. But because it's effectiveness research, we do want to mirror, how would telemedicine happen within clinical settings? So thinking, Lisa, do you do telemedicine in solid ground wellness and recovery? And do you set any parameters? Do you ask patients, for instance, to be in a quiet place?
Yes, in confidential settings to make sure that there's not other people that are hearing, that we try to provide the earphones if they don't have them, so that they're not, sometimes they're transferred, on a bus, so they'll be on listening to group, but if they have that on speakerphone, that's going to be problematic. So it's confidentiality, not just for the client on the session, but also those around them and the other people in the sessions.
Okay. So if Lisa is our partner, we're partnering with Solid Ground Wellness and Recovery, and we want to replicate how they deliver telemedicine and how they deliver in person, then we want to think through, patient health information, things like that. We want to make sure that our participants have access to audio phones, that they know that part of their being in this study is to use those audio phones so that when they access their telemedicine session, their telehealth session, that they're following what our expectations are for being part of the study. And given that we're collaborating with a healthcare organization, we also want to replicate we want to mirror some of the things that they're already doing, because we want this to be as similar as to what our collaborating partner is doing, right? So then we do our study, we do pre and post tests, we follow them, or they're part of, I think it's 25 sessions. And then in the end, we do our analyses, and we find, and also, we ask a lot of questions about access, digital access, healthcare, digital access, children in the home, other people in the home, descriptions, just essentially to understand the context, the larger context in which the individuals in our sample exist. Remember, they're all students in the UC system. And so then in the end, we quantitatively determined that telemedicine, those in the group of telemedicine seem to have better outcomes. So they have reduced PTSD symptoms over a 25-week period compared to those who were in the in-person sessions. What we notice is that from our tracking, a lot of the individuals who were in the in-person sessions, they either showed up late or they struggled to get to the clinic, or because it took them so long to get to the clinic, we noticed that they weren't as focused in comparison to the participants who were in our telemedicine group. And we can get this from observations. We can also get it from doing, so we did observations. We also did some one-on-one interviews, and we asked satisfaction questions about the different interventions. So this is an example. In this case, what we would recommend to Lisa, we would say, Lisa, it seems that based on our research, we would want to recommend providers like you and other providers. And let's say, there was other organizations involved in our research, we would want to recommend that when we think about the treatment of student patients, that telemedicine for this certain patient population tends to work better than in person when we're thinking about the delivery of seeking safety for PTSD symptoms. And so, like maybe it was a pilot study that we did, and so we'd want to do a larger study. We would want to make sure that over time there's more evidence creating to make sure that we have confidence to share with clinical practitioners, for instance, our recommendations based on the research evidence that we have of what we would recommend in terms of the delivery of seeking safety for this specific student patient population. If both worked equally as well, then we could say the delivery of seeking safety for this student patient population for reducing PTSD symptomology, either via telemedicine or in-person works. And we could recommend, based on evidence and based on the research, that both delivery models could be used. So I'm going to pause there and see if there are any questions, comments.
There was a comment in the chat. So they were asking if, for instance, it could be like a case studies or a survey. But I think like you responded to some of those questions.
So definitely with the methods, we could think about using both. So we use surveys particularly to be able to understand change over time, from the beginning of an intervention to the end of the intervention. We could use a case study. We could follow, for instance, specific individuals, and have a more in-depth understanding of their satisfaction, their experience with the intervention, maybe more points of data collection to understand at different phases or different points in the study how they're responding to the intervention. So certainly that could be part of the methods that we would use in the study. Okay, any other questions?
So, and Dr. Cheney, the similar would be if we had people that came in that were abstaining from alcohol, both experiencing cravings, and then one of them were given cognitive behavioral therapy services, as opposed to another one that would be getting maybe some Vivitrol medication to help those cravings, and then you'd be able to compare the effectiveness of being able to go through those cravings without relapse and those types of things. This is same thing, right? Similar, or because they're getting one medication and one's not getting medication, it's still comparative effectiveness, yes?
Yeah, so in this case, what you would be comparing, so you wouldn't be necessarily focused on the delivery. You'd be looking at the interventions, and you'd want to choose interventions that have been proven to have an evidence-based practice to impact the outcome you're looking at. So if you're looking at, what did you mention, Lisa? Alcohol use?
Yes, it's for cravings for alcohol use. So that it actually is shown to be evidence-based, useful, the Vivitrol, but that's kind of what we're talking about. That's
exactly
two different tracks of people, but it would be who's able to sustain the abstinence longer, those with medication versus the ones without.
Mm-hmm. Yeah. And so you just want to make sure that both of the interventions in the comparative clinical effectiveness trial, that they are evidence-based, they've proven to be evidence-based, and then you would randomize your patients to one of the intervention arms, and then you would see which one is more effective, meaning that has a better impact on patient outcomes. It's the same outcomes you'd be measuring, right? And that would allow you to better understand which one you would recommend in the future. Well, it's research, right? So we're sharing it not just within our clinical setting, right? It of course could have implications, but with research, we want to go beyond what we might consider quality improvement to understand how is it going to contribute to generalizable knowledge. Evelyn?
Mm-hmm. Yes, I just would like to add that in case, going back to whether it would be in person or will be via telemedicine, it is important for the team to follow the same procedures. So if you're saying we are going to follow 4 steps, so you have to follow the same 4 steps in person, but then also online, because otherwise then there will not be fidelity on what are we measuring or what are we following. So then that is going to change the findings. And of course, we will not be able to compare.
Yes, thank you very much, Dr. Vasquez. Assessing fidelity is very important. I just want to point out, this is in relationship to a comment made earlier based on what Dr. Lakes has shared about ethics. So when I think about comparative effectiveness trials or clinical effectiveness trials, very much, I think that this is when we think about ethics, and particularly underserved patient populations, if we consider graduate students, historically marginalized graduate students, in a CER design, it means that everyone who is part of the study gets access to an intervention that we already know based on research is evidence-based. So we know that as a researcher, as academics, as patients who might be involved in the research team, or as healthcare providers, that individuals won't necessarily, you can add a control group, but the idea here is that you have 2 different interventions at least that you are comparing. Okay. Any other questions? Okay, so I'm going to pass it now over to Dr. Vasquez.
Thank you so much, Dr. Cheney. This has been very, very helpful. And we also right now would like to invite our attendees to please take a few seconds or minutes to please help us to respond to our post-event survey. So remember that the main goal of our project is to develop capacity in different stakeholders, including grad students, clinicians, and then also healthcare providers, to be able to have this comparative effectiveness research. So we want to know what could be some of those research topics that we can further explore. And just please keep thinking that the main patient population that we are looking on this project are historically marginalized graduate and professional students. So we are going to share the link as well in the chat, or else you can use the QR code. And then here also you can see the upcoming events that we will have. So we will have our virtual photo voice gallery in a couple of weeks on March. So we will be also sharing the link for you all to access our inaugural talk, and then also the link where you will find the virtual photo voice gallery. Then we will have our mental health educational workshops. We will start these workshops in April. And here you can see some of the different topics that we will include. Yes, thank you. And next slide, please. Thank you. And then just as a reminder, as we always do, here are some national resources that you can use, but also you can share with others. So the National Suicide Prevention Lifeline, SAMHSA, and the National Alliance on Mental Health. And remember that you are not alone, and we would like you to follow us on Twitter, or also look at our website, and also just keep your eyes open to hear more about our upcoming wonderful events. And I also would like to say thank you to our leadership members. And then also I see here some members of our mental health task force today. So thank you so much for being here, as you are instrumental to our project. And thank you so much for your attention. Please let me know if you have any other questions, and then also or any other comments or suggestions to improve our project and engage more graduate and professional students. So I would like to know if anyone else from our team would like to share any ideas or reflections in this training, but I know it has been extensive, but thank you so much, Dr.
You are welcome, and I will stop